I do have Dr. Isaias Irgau from Chrias and Surgery Center, American Surgery Center with us. Dr. Irgau, if you can please introduce yourself.
Thank you, Kemal, very much. Hello, everyone. Thank you for tuning in. As Kemal said, my name is Dr. Irgau. I am the president of the Christiana Institute of Advanced Surgery and the medical director of the bariatric surgery program at the American Surgery Center. I am a general surgeon and I specialize in bariatric surgery, which is weight loss surgery. I have actually been performing weight loss surgery now for almost 20 years. Myself and my associates, Dr. Gail Wynn, Dr. Michael Peters, Dr. Raul Singh, and Dr. Georgie Ibrahim were all board certified specialists in bariatric surgery. And we are by far the most experienced practice when it comes to bariatric surgery for our area and also in Delaware, but also for the surrounding counties in Pennsylvania, Maryland, as well as southern New Jersey. I'm very happy to be here today to talk more about bariatric surgery, which is really a great passion of mine.
Dr. Irgau, thank you for that introduction. So most of the people who are following us, they already know you and I, we've been working together with our group since 2003, but Chrias did start even before that. So if I can just ask you first, when the first bariatric procedure is performed by a Chrias surgeon, when was that? And how many have you done so far since that time?
So the very first bariatric procedure was done back in October of 2001 by myself and my associate, Dr. Gail Wynn. Both of us did the very first gastric bypass procedure in northern Delaware at that time, at least gastric bypass in the modern version of it. We have actually since really introduced the laparoscopic gastric bypass and firmly established that technique in our area. She and I really have started and established centers of excellence in the main areas, health systems. And my group has performed now well over 7,000 very successful bariatric surgeries since we've been doing bariatric surgery.
So those numbers are extremely big. Now, why is it important to do so many procedures from the surgeon standpoint and from the patient side? Why would that be important for us from the patient perspective?
Well, that's actually a great question, Kemal. So clearly, in any area of medicine, experience is important. So an experience comes obviously from how long you have been dedicated to doing a particular specialty or a particular procedure. But really, it's even more important when it comes to bariatric surgery because bariatric surgery has had really a bad rap to begin with because it was seen first of all, as a procedure that was not very necessary because people thought that people should lose weight by themselves, particularly people who never struggled with weight, really never understood the necessity of bariatric surgery. We're really very, very, very pleased now that we have reached a stage in which bariatric surgery has been accepted as a very important treatment for this very, difficult disease, which is morbid obesity. However, we had to prove ourselves. We have to really go beyond any standard to make sure that bariatric surgery is very safe. And we have established that by really performing and perfecting the procedures over time to the extent that now in very experienced hands like ours, a very complex procedure like the sleeve gastrectomy or the gastric bypass have a similar safety profile to gallbladder surgery or hip replacement surgery. So experience is obviously very important, particularly in bariatric surgery, because it's an area that has been scrutinized so much in terms of its outcomes.
So Dr. Irgau, so it's been almost, again, 17 years for me. And I think in the last 10 years, we are on the management side. We work much closely. Now, the different types of bariatric surgery, I know from our patients, this is one of the questions that comes up all the time. What's the best way to decide for the surgery and which surgery is best for the patient? If you can kind of elaborate the type of procedures for us, and then how is one that's being picked for the patient, how we are deciding, and what that process is.
Absolutely. You and I talk a lot about this, Kemal, because clearly these are procedures that we know very well, and but also our patients, part of the interaction is really education really making them understand the benefits and the advantages of each procedure, right? So we talk about this a lot. So I'm actually going to, first of all, introduced by saying that all these procedures that we perform are geared to making some change on the digestive tract. That's the area where we are really working on, okay? Because the digestive tract not only is the system that really processes food when we eat, but also now we know it's an extremely important system in determining some very important process known as metabolism. A slow metabolism puts us at risk for weight gain. A faster metabolism gives us the advantage of staying thin and healthy, right? So that rate of metabolism very often decides how well a person processes energy. So if their metabolism is not helping them, they will gain weight very easily, and it will be very hard for them to lose weight. If their metabolism is helping them, they will lose weight whenever they want, and they will stay thin and fit. Right? And what we have discovered with bariatric surgery is that making changes in the digestive tract also results in very, very important changes in metabolism. That's why, hands down, bariatric surgery is so much better than diets and other methods. Now, going back then to what kind of changes we introduce with bariatric surgery, I'm going to actually ask you to help me with your pointer to show people each procedure when I point. So we will start with the adjustable gastric band, which is the procedure that you're pointing at right now. The adjustable gastric band essentially is a procedure whereby we place a device in the upper portion of the stomach to tighten that portion of the stomach and really modify how easily food passes from the upper portion of the stomach to the rest. This is a procedure that we do less commonly. There was a time in which we used to do a lot more of gastric banding, but we do a lot less commonly now. The next procedure that comes after that is the sleeve gastrectomy. Okay, the sleeve gastrectomy is a very different procedure, obviously, because in this procedure, we actually change the volume of the stomach. So we cut the stomach in such a way that a large portion of the stomach will be removed completely and only a small portion of the stomach will be left behind. Actually, if Kemal, you want to go on your next slide where we have a picture of the sleeve gastrectomy only, I will be able to elaborate that.
That's a stupid question. Well, actually, I mean, sure. I think I shared another question, but I shared this with you maybe in the past. So although we are in this for so long, so until maybe 4 years or maybe 3 years ago, I was imagining the sleeve being, you know, you are cutting the stomach and then you are just actually wrapping the smaller part with the extra part. So that's kind of like sleeve. That's how I'm actually imagining it. So then it wasn't until we went to that place in Seattle. So then I realized, okay, what I knew was wrong. So I didn't want to actually tell you first that I was wrong. Like I was thinking differently. So, but it's interesting. So like, we don't really understand this it's like, it's so simple for you guys from the surgical side, but from the patient side, even for someone who's in this business for so long, yeah, I mean, my entire life, professional life, we are in healthcare. I'm in healthcare. So, even for me to miss that, just because we didn't know, if you can kind of just walk us through, because this is the most common procedure we do.
Absolutely, absolutely. Kemal, actually, you didn't miss anything. You just used your whole common sense, because when you hear sleeve, that's what you do. In fact, many patients think about when they come asking for the sleeve, they're actually expecting for us to wrap the stomach with some type of sleeve. It actually the sleeve word comes from the fact that when surgeons saw that they were making the stomach very thin, almost like a pipe or almost like a banana shaped, they were thinking about a shirt sleeve type of shape of the stomach. You can imagine surgeons don't have really too much imagination when they're naming things. That's why they named it sleeve gastrectomy, because the final shape of the remaining stomach looks more like a sleeve essentially. But the idea essentially is to cut the stomach in such a way that you are removing the stretching portion of the stomach and leaving the stomach that is much tighter and much smaller. But importantly, also you're leaving a portion of the stomach that harbors many of the signals of hunger. So it's not unusual for our patients after the sleeve gastrectomy to actually forget completely to eat because they're not hungry at all. They have to remind themselves to eat. So that's a very important component of the sleeve gastrectomy. So we are removing a greater portion of the stomach and leaving really a tubular, a banana-shaped stomach behind. As you correctly say, this is by far the most common procedure. And clearly, it is a very safe procedure. It makes total sense in the minds of patients when they're thinking, okay, a big part of my stomach will come out, so I will be left with a smaller stomach that takes less food, and I will be less hungry, and that makes sense. But the advantage of the sleeve is not just based on this mechanical restructuring of the stomach. Also, we have discovered that it has incredible metabolic powers. It affects how the body processes, for instance, blood sugar, how we are able to maintain our blood pressure. These are the metabolic benefits of the sleeve gastrectomy.
So, Dr. Irgau, you said it, but I want to make sure that some of the questions that I'm asking is for those who may not be able to ask these questions directly. So this is not just about making the stomach smaller, right? So, and then those are the things that we pick up like later on. So the part that actually makes us hungrier is the part that you are removing. So yes, it's like, other than being just having a smaller stomach, there's also that other part which actually makes the weight loss almost guaranteed if people are following the correct process after the surgery.
Absolutely. Absolutely. So that's important. That's important because really what we're doing here is that we don't want to end up in a situation where the person loses weight and then the body adjusts the metabolism of that person so that the person is famished again and they will eat more and more to regain the weight, which is what happens with diets. We want to have an impact on the metabolism. In fact, you know, it's very interesting. The society that we belong to, the meetings that you and I have gone to very often, the American Society of Bariatric Surgery, its original name was American Society of Bariatric Surgery, but we've changed that name to become American Society of Metabolic and Bariatric Surgery, because what we're doing is not strictly to just make that person lose weight, but also to impact their metabolism so they become a lot healthier. And that is what primary care doctors have discovered in bariatric surgery, because they were seeing their patients who are having a sleeve gastrectomy come into their office not only about 60, 70, 100 pounds lighter, but also with a normal blood sugar if they had diabetes before, with a very well-controlled blood pressure if they had high blood pressure before, with a low cholesterol level if they had had cholesterol before, with no sleep apnea if they had sleep apnea before. So one surgery impacting so many diseases, because the flip side of that is that obesity is causing all these problems because it deranges our metabolism. So these are powerful tools that we have with the surgery. So the sleeve gastrectomy from that point of view is has proven itself to be very powerful as well.
So Dr. Irgau, as we spend so much time on the obesity and the management of the obesity, what can be done, as most of the people who follow us, they know we have accountable care organization, yes, which actually has different wellness programs to make these things easier to manage from the chronically ill patients. So we know that obesity was not recognized as a chronic disease until 2010 by Medicare.
Yes.
And then there's one part of it that now the medical society, they accept this as chronic disease. The other part is the society itself is still discriminating. While we are actually discussing today what type of procedures patients may be getting, how to decide, there's still this discrimination against the obesity, and this is coming from not understanding what this is and how what people are dealing with. So my question on this is that how do I, like if the patient comes to you, for example, and I'm hoping that people also understand that you and I, we don't just sit down and rehearse these. So like 70% of the questions, you don't know what's coming. No. So if I come to you as a patient and I say, well, I want to get this procedure. Like I'm already said, I already did my own, everyone is the Dr. Google these days. So including myself. So then we just search, oh, I'm like, this is the right procedure for me. Now I come to you and I say, I want to have gastric bypass. What's that process from your side? How you actually guide that patient and how we can actually decide that right procedure? What do you guys do in those cases?
So it is actually very important. It's very important to really be open and listen to what the patient is expressing. What is it that the patient wants? What is it that the patient is expecting? Remember, we all, as you correctly said, will come with our own perceptions and ideas of what we want to do, but we come to an expert like myself also to get an explanation and an understanding whether that's appropriate in that particular setting. Remember, you and I are talking in general terms now, but it doesn't mean that a particular patient will necessarily fit within a certain treatment pattern, not at all. In fact, that's why the interaction between the surgeon and the patient has to be extensive enough for the doctor to be familiar with that patient, to understand their background, to understand their medical history, to understand medications that they are taking or illnesses they have been exposed to, surgeries that they may have had in the past. All that will come into play when we decide what procedure to do. Now, bariatric surgery, as opposed to other treatments, is not something that can be imposed. Remember, we're not saying you must have this operation, not at all. What we do is we educate the patients about the benefits and risks, advantages and disadvantages of all the available options. And then myself as a physician and the patient together will come up to an understanding at what might be best, right? Now, this introduces actually the issue of gastric bypass. If you don't mind going back to that slide, the original slide with all the procedures, I can a little bit elaborate about gastric bypass. So with gastric bypass, also as opposed to the sleeve gastrectomy, yeah, if you're putting that correctly, with gastric bypass, what we're doing is not only we are cutting the stomach and making it smaller, but also we are rerouting the intestine so that the food avoids entry into the early portion of the intestine. That's what gastric bypass is essentially. That this procedure is different from the sleeve gastrectomy in that it involves the rerouting of the intestine. We used to do a lot more gastric bypass before the sleeve gastrectomy was popularized, because in fact, myself and my two more senior associates, Dr. Wynn and Dr. Peters, have done really thousands of gastric bypasses before the sleeve gastrectomy was popularized. With the sleeve gastrectomy, what we've discovered is we can achieve similar results without rerouting the intestine. But the gastric bypass still has an important place. For instance, people who've had very severe, and I have to stress this factor, severe reflux to the extent that they've had damage to their food pipe, the gastric bypass actually is a better procedure because it's a cure for reflux as well, right? But in the vast majority of situations, the results that you obtain with gastric bypass can be obtained with the sleeve gastrectomy as well. So patients, as you correctly said, will come up with, after they've done research, after they've been exposed to friends and family who've had a certain procedure at the same time, and their view on that procedure will be colored by the experience of that acquaintance, obviously. So if the person has done well, they will be viewing that procedure favorably, and vice versa. When they come up, we review their medical history, we look at their comfort level, and then we expose them to the different procedures, and then together we'll make a decision. Having said that, as I said before, the most popular procedure that we're doing right now is clearly the sleeve gastrectomy because it can achieve similar results to those of gastric bypass without having to reroute the intestine, which by itself does have consequences long-term, essentially, not least of which is malnutrition, because when you reroute the intestine, you're also making the person less able to absorb important nutrients like vitamins.
So, Dr. Irgau, the other question that I have is MBSA QIP. Now, if you can elaborate what that is, why do we need it, and where American Surgery Center is to get that certification?
Absolutely. I mean, actually, this goes back to your earlier question, Kemal, the issue of experience, right? We want to make sure that bariatric surgery is done in a setup that provides the maximum safety for the patients, right? That's the number one priority. And you can do that if you have a system with checks and balances that can be answerable to a body that is national, right? A national body like that of the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery, which together have come up to set up this criteria that centers have to fulfill to become eligible for the MBSA QIP accreditation, right? And as I mentioned before, myself and my associates actually were the first to set up centers of excellence, even in the major hospitals in our area, by setting up programs that include experienced surgeons, nutritionists, psychologists, internists, coordinators, who all together are really looking after the preparation in terms of evaluation and education of the patient, safe surgery, but also follow-up long-term to make sure that that patient remains successful and remains healthy after the surgery. As you mentioned, the American Surgery Center that you are the chairman of actually is one of very few ambulatory surgery centers in the whole nation to be accredited by the MBSA QIP as a center of excellence for bariatric surgery. And the key there is that you are able to perform a bariatric surgery in a very safe environment like a surgery center where most people will go home the same day with fantastic results. And as we've shared in our previous discussions, the review that you get in terms of patient satisfaction after having been through the American Surgery Center is through the roof, essentially, with great satisfaction in terms of the nursing care, in terms of the preparation for the surgery.
So, Dr. Thank you for that. So, I think we are one of either the number 14 or number 15 in the nation from the surgery center side with the MBSA QIP certification, and we are proud of that. What we know with our team, we have invested in this a lot. Now, you and Dr. Gail Wynn, Dr. Mike Peters, Dr. Rose Singh, Dr. George Ibrahim, you guys have done a lot, but you yourself, Dr. Wynn and Dr. Peters, and actually Dr. Singh, we were running the hospital programs before, and we still are running the St. Francis under the leadership of Dr. Gail Wynn, and we do procedures at these hospitals, specifically at St. Francis in this case. So getting the patient ready for the procedure is extremely important. Now, I do participate and share some of our daily case conferences, which I know that it helped me a lot to understand what patient has to go through. So in some cases, we see patients with high BMIs, like these days, I kind of criticize myself, like I probably put 15 pounds during this time now, but my BMI is still like 27.9, maybe it's like 28.1, but I'm lying maybe. But that even is putting us on a different edge. But we are talking about patients who are over 40, 45. Like today we had a patient who actually quit the process and BMI was 57. Yes. And my initial reaction was, oh my God, like someone at 57 and she was almost done with the process. How can she afford not doing this?
Yep.
And so that's kind of like the patient groups that we have. and the management that we provide, the clinical management that we provide. Now, from the for those patients who are looking for this, I'm assuming that you would agree with me that one of the most important thing is to watch these events, yes, because we are making these available. It used to be like, you know, it's kind of interesting how this whole pandemic actually turned different things into different forms. And I believe there's always some good in everything that we go through.
Absolutely, I agree.
What we learned from this is the virtual meetings, remote meetings, telemedicine, telehealth. And what we are doing, we wouldn't be probably doing this if we didn't have the pandemic today. And this is our like the third or fourth event in the last 2 weeks. And we have done at least twice a week, and we make these available for the patients. The other thing is that our next step would be having the consult with our surgeons and then see what would be the right procedure for the patients, for you to go through. Now, well, I did kind of mention this, but Dr. Irgau, but you and I right now, we are doing this Facebook Live, and this is new for us, right? Like you were just seeing patients earlier, and you are going to probably see patients later on, or you may be called into the hospital for some emergency. Why are you doing this?
So, as I said, it's a passion of mine. It has become a passion. And it's interesting because I entered this area actually in a very, very unusual way, right? When I finished training and I was beginning my general surgery practice, I wanted to be very good at something called laparoscopic surgery, which was really coming up then, which means making, you know, doing big procedures, complex procedures through small incisions so people could recover faster, so they don't have to struggle with a long incision that has to heal like our teachers used to do essentially. And one of the most complex procedures that really pioneering surgeons were doing at that time was gastric bypass. So I wanted to learn about gastric bypass, and I started going to meetings. Remember, when I was training, no one was doing gastric bypass. No one was doing laparoscopic gastric bypass. We didn't see that at that time, right? And if people were doing gastric bypass at that time, they were doing open gastric bypass with big incisions, you know, which had problems of itself, essentially. So I went to learn about laparoscopic gastric bypass, and I discovered bariatric surgery. I discovered that a surgeon actually can give people their life back if they have been struggling with 100 pounds, 150 pounds, or like that lady you mentioned, almost 200 pounds of extra weight, day in and day out, with the added problems of diabetes, high blood pressure, sleep apnea. So I discovered that I could offer a treatment that would free people up from all these diseases. One of the highlights of my career, Kemal, I have to tell you, is probably about 12 years ago, there was a gentleman that I had operated on. He lost almost 130 pounds, came back to me saying he was of disability. He was going to go back to work again, okay? And there's nothing more satisfying for a physician than see people going back to having, you know, quality of life. And that's what happens with bariatric surgery, really. It's a really gratifying field from that point of view.
Dr. Irgau, I do want to answer a couple of the questions from the audience. We are making these events from you and I's standpoint, we are making this pretty topic focus. So then people who are watching this later on, we can actually see what they want to kind of watch and like type of procedures before surgery, after surgery. We are going to do different events. One of the questions is right before the surgery, we have the post-op appointment, the clearance for the surgical clearance. I'm sorry, surgical clearance appointment. So can you talk about the 2 weeks diet that they have to go through?
Absolutely. So what we have discovered is that when we are struggling with weight and we are heavy, one of the organs that really becomes very heavy is our liver, which is a solid organ, right? The liver is actually right over our stomach in its position inside the abdomen. And when we do surgery, if the liver is very large, that can make the surgery difficult in terms of exposure of the stomach and safe performance of the surgery. And what we have discovered about 12, 14 years ago is that if we put patients on a specific diet, which is high protein, low calorie diet, nowadays we use the new direction diet, patients actually lose some weight, but more importantly, they end up shrinking their liver. The liver, instead of being heavy and difficult to push, it becomes very flimsy and very easily mobile. And that is a huge advantage in the safe performance of the surgery. So we've been doing that since then. And I cannot remember any procedure where the liver was a problem, since then. So it's a diet that we have adopted. It's mandatory for all our patients because really the safe performance of the procedure very much depends on it.
Dr. There's one other question that I would like to ask you. How much of the feeling of hunger is from the brain versus stomach? Is the feeling hungry from the brain or stomach? So it's kind of like
That's a great question. That's a great question. The answer to that is probably a bit of both, okay? Remember, we are living in a society right now where actual physical deprivation of food for long periods of time is not common, right? Because food is relatively easily available, at least in the United States. It is, right? So real deprivation that leads to people looking for food because physically they need energy is not very common, right? The flip side of that is the availability of food really introduced a culture where we eat not necessarily where we're hungry, but for pleasure as well, right? So very often when we're driven to eat, it could be a mixture of both. Now, which means that we could be mentally hungry or partly physically hungry as well. And we have a hard time differentiating that, right? Now, after surgery, some people may experience some hunger just because of that need to eat that their mind is trained to do, right? So part of getting used to really living after surgery is also to understand that. The good thing though, Kemal, is by far the vast majority of patients do not experience even mental hunger after the surgery, which is very interesting. Their relationship with food actually changes in very, very interesting ways. Another thing to mention there is that very often also we mistake thirst for hunger, right? Water, in fact, is far more critically important on a very frequent basis for us as human beings, as compared to food. And yet, very often when we are thirsty, we think we're hungry. But the thirst goes away when we eat because the food that we eat has a lot of water in it. So when we're eating, we're also drinking water because the food contains water. So that confusion actually persists. So I teach my patients actually to really try to drink a lot of water so that they don't mistake thirst for hunger as well.
And I do want to mention, Dr. We have 3 nutritionists with us, and with the leadership from Amy Wilkinson, we are doing an online event twice a month on Wednesday nights. So we do have our next event this Wednesday, tonight at 7 p.m. So our followers can actually see the link directly from our Facebook site. Now we are going to be doing more and more of these events because we understand that personally we are going through this first, like we are struggling with everything that our patients are struggling from the personal side. And as we were just doing some of our webinars, we said, what's the best way that we can actually reach out to our patients, our community in a way, because we are also meeting with our providers 3 times a week. A lot more meetings are happening. So with these events, we are trying to keep the information available to everyone, make sure that you are not by yourself, you are not alone with what you are going through. So because I have done so many of different types of these meetings, in some cases I can be in the different programs and speak from the different perspective. But what it all comes down to is what we can do to help the patient to go through the process in the best way. Surgical, non-surgical, this is all about what's right for the patient. So if we can actually help and be a resource for anyone, that would be the most important thing that we are able to accomplish. I'm hoping that everyone is finding these helpful and useful. Dr. Irgau, I know taking time from the clinical side and kind of getting you with us, and because doing it together, it makes a lot of it makes it more enjoyable. But I think it's also more beneficial for our.
I agree. I agree.
Patients. So thank you for joining us tonight. Today.
Thank you. Thank you. Thank you, Kemal.
See you in the next couple hours. Thank you so much.
Thank you, everybody. Bye bye now.
So we'll see you soon. Bye bye.
Bye.